So today I will speak about the movement for humanization of childbirth in Brazil. And this is the presentation outline. First, I'll tell a bit about Brazil, and then I will speak about the movement for humanization, but also some of the biological issues that the new interpretations of biology, they are behind this movement for humanization of childbirth. So Brazil is in Latin America. You can see it's almost half of the subcontinent. I live close to the Tropic of Capricorn in the state of São Paulo, but I'm from the northeast corner of Brazil in the state of Rio Grande do Norte. So I'll tell some of the indicators, socioeconomic indicators about Brazil. In Brazil, in last decades, we had a very important decrease in poverty and inequality. We had an increase in average income in this last year, especially from 2002. We had, in terms of gender distribution, we have more or less half and half. Women are a little bit more, especially related to the fact that we have an increased mortality of men, especially young men, due to violent causes. A bit about the population. Brazil has over 200 million inhabitants. We have 5 geographic regions. 93% of the households have water supply. Sewage systems, about 60%. Almost everybody has electricity. More than 90% have a refrigerator and television. It's much related also to having electricity. And broadband use of the internet is very high. And some of the most important public health issues are related to non-communicable disease. We have a national health system. We have universal health care. And the public health care accounts for about 75% of the Brazilian citizens. But we have 3 subsystems, which is the public one that's provided by federal, state, and municipal levels, a private non-profit, and a private for-profit, that are health insurance. In the last decades, we had a very important decrease in infant mortality. And the perinatal component is the most important one. This is important because this is very much related to quality of care, especially perinatal health care. And in terms of maternal mortality and other demographic indicators, our fertility rate declined sharply in last decades. We have about 1.8 of our fertility rate. This is the data of our last census that was 10 years ago. So fertility in Brazil continues to decline. We have access to antenatal care and birth care is practically universal. We have not only in remote areas. And the maternal mortality rate has remained stagnant on around 50 deaths for 100,000 live births. So the main causes in Brazil are hypertensive disease, sepsis, hemorrhage, and complication of abortion. Abortion is illegal in Brazil, and that's an important cause of mortality. In some regions, it can be the second cause. What are the barriers to decrease of this maternal, neonatal, and perinatal mortality? We think that the issue of quality of maternal and child health system service is very variable and sometimes insufficient. That's unnecessary obstetric intervention. There's very little, there is an underestimation and neglect on information about adverse effects, poor integration between the systems. There is some pilgrimage between hospitals, and we have little variation in terms of providers. Although Brazil has very good indicators in terms of access and maternal mortality, we have many concerns about the quality. So one of the things that are the problem is the trends of C-section that being raising until a couple of years ago when they started we have in the last couple of years small decrease. I'll tell you a little about this. So about the movements of humanization of childbirth, as we say, this is a picture of a plenary of our network for the humanization of childbirth. So this movement is very much based on, I would like to say, two main components. It's very much devoted to promoting rights, the rights of women, of children, and the rights to health. And the other pillar, let's say, is the idea of the right to evidence-based care. So it's the humanization of childbirth movement is very much related to promoting and to implementing evidence-based, safe, effective care. See, these are two of the publications that were very important to this movement, especially the Care in Normal Birth, a Practical Guide, that was published by WHO 20 years ago. And the other one is the Cochrane book on childbirth. It's called the Guide to Effective Care in Pregnancy and Childbirth, that was edited by the Pregnancy and Childbirth Group. Those people who were in the last lectures, I was telling about the story of how this group was put together, how it started the collaboration for systematic reviews and meta-analysis in the area of perinatal care. So a bit on, we in the movement for humanization of childbirth, we very much deal with this idea of innovation in public health. So in Brazil, we think that innovation sometimes is incorporating technology, and sometimes it's withdrawing technology, but mostly it's about implementing safe and effective technology. So here are some of the examples that I brought here that are, for instance, kangaroo care, having new settings and ambience and routines for childbirth, relactation, and so on. So we work very much on implementing safe and effective care based on these ideas of that are promoted by these guidelines based on systematic reviews. So for us, innovation is a technical change in the way or a new way to acting in the work process related to health promotion or disease prevention, which has an effect on the epidemiological situation of a given population. This is easier to be said than to be promoted because services sometimes are very resistant to change. So we work with the whole methodology of changing services. One of the main problems is, although we have 20 years of very well-designed and rigorous evidence about how care in childbirth, for instance, could be, we have the change is very slow. So this is the reason why this network is so important. We were funded, the network in 1993, so we have more than 20 years working on changing institutions. So the network, its composition is very multiple, it's very diverse. We have providers, we have feminist activists, we have scientists, we have academic people, we have grassroots, we have policymakers, and we work together for changing services. So we work a lot with managers and with policymakers. So these social movements are also very close to also the training of health providers and women's groups. We resumed the training of university-trained midwives. We work a lot with doulas who are birth companions also. There are lots of recent systematic reviews about the importance, the safety, and the effectiveness of using birth companions and the midwives and the importance in any health system. So these days we're having a third international conference on humanization of childbirth. It's going to be that's starting this weekend in Brazil. This is the poster. So in the last years, we are also one of the movements. The women's movements have been working for humanization of childbirth for these many years. But in the whole Latin America, that's a growing concern about what's the reason why this these services are so slow to change. So people started to call unnecessary, aggressive gender violence. So this has a huge appeal in Brazil, in other Latin American countries. And recently we had, 10 years ago, we had the creation of several women's network. One of the network is the Parto do Princípio one. And they organize to educate the providers about evidence-based care, saying that excessive intervention and non-consented intervention are a form of violence. So several countries in Latin America have already typified obstetric violence as a form of gender violence. And in Brazil, the issue of obstetric violence, of abuse and disrespect, has become a very important academic and research topic. And one of the research by the Perseu Abramo Foundation made this research showing that 1 in 4 women report have been abused during childbirth. And that in recent years, there's been the establishment of International Initiative for Respectful Childbirth Care. That's the White Ribbon Alliance. And in Brazil, all over Brazil, in many states, there's been this hearing, public hearing about obstetric violence. There's obstetric violence videos to inform and to educate the public about the issue, and very much consolidating this as a research object. I will tell the students about the research we are doing about implementation and how people are using the framework of abuse and disrespect to help implement evidence-based, safe, effective care. The social movements in Brazil have a slogan that, trying to translate this into English, we would say, no more violent delivery to self-C-section, because people believe that the acceptance that women have to C-section in Brazil is because women do not have the chance to have a spontaneous birth where they are treated with respect, where the care is effective, is safe, and women can have a calm environment with a companionship, choice of interventions. Women are not allowed to this. So comparatively, many times a C-section seems to be a safer effective intervention. So this is a picture from a service that many hospitals in Brazil offer, which is the Cine Parto, Cine Childbirth, it would be in English, which is the woman books for a C-section, and everybody is in another room, you know, and it's transmitted, you know. So they book for a party and a buffet and etc. This means that women do not have the chance to have a spontaneous delivery because this has to be elective. And I'll tell a bit about the health consequences of this form of health care. So presently, if you get to the best evidence, both the biological evidence, the epidemiological evidence, and the biological evidence, we believe that the gold standard, the best results of care for healthy women, which are 85 to 90%, would be having a full-term delivery. It's a delivery after 39 completed weeks, because we were educated to think that term delivery would be from 37 completed weeks. This has changed, you know, and we have to update our agenda about this, because babies born before 39 completed weeks have different outcomes. That ideally, spontaneous onset of birth, you know, because this sign of maturity for healthy women, when women are not induced, if they don't have a clinical indication for that, and it takes place preferentially without the use of drugs, because drugs have side effects. So we are part of a coalition that improves the reporting of adverse events of drugs in childbirth, and this is really scary, especially the use of oxytocin and other drugs. The mother, ideally, some women will need interventions, and it's very important that women have the medical intervention that they need when they need, right? But most women can go to her postpartum without any kind of surgical wound, because surgical wounds have additional risks and discomfort and disturbs breastfeeding and so on. When meaning no wound, that means without C-sections, but also without episiotomy or lacerations that tears, vaginal tears that need suturing. The priority to the physical and emotional comfort for the mother and family, and the technology used can be the minimum compatible with safety and comfort that may be none other than qualified observation. I will talk a little more about this. And the provider, and it's very interesting, the recent reviews, systematic reviews about this in both developed and developing countries, showing the many advantages of having university-trained midwives in a hierarchical system that women could be referred for complication. They have the very best outcomes. So we are part of an initiative, and we are piloting in Brazil a research for implementing this initiative that's called the Mother-Baby Friendly Birthing Facility Initiative. We are piloting this in 2 training hospitals in the public sector in Brazil. This is very interesting. This is a recent publication by the International Federation of Gynecology and Obstetrics. It's a very interesting one that describes the rationale for the intervention and the indicators for this process of change. And also, we are part of a collaboration that develops methodology to assess and to measure what's called the global epidemics of abuse and disrespect during childbirth. So this is a paper that's a very interesting one. I'm leaving the presentation, so you can, if you can copy it, and all the references are there. For what we call the global epidemics of abuse and disrespect in childbirth. So this is a paper about the history, evidence, intervention of the FIGO, Mother Baby Friendly Birthing Facilities Initiative. I will go in much detail on this on the presentation that I'm going to do next week, but it's a whole new interpretation of the biology of the perinatal period, especially childbirth. So I strongly suggest for those people who like physiology, that's many new research on this. They are very well synthesized by this publication. It's free online. You can get that in the Childbirth Connection website. It's called The Hormonal Physiology of Childbearing, Evidence and Implication for Women's Baby and Maternity Care. It's an excellent book. This book it has over more than 200 pages, but you have shorter version, you have an executive summary, you have translation, let's say, of this for consumers, for families. It's a very interesting. You have it in English and in Spanish for those who are interested. It's very, very recent and very good. So I'm going to describe a bit about this new interpretation of biology of childbirth and how it impacts the organization of services. So we used to think of childbirth as a very mechanical event. In Portuguese, we would say that we have the root, the object, and the motor. In our obstetric books, that I learned, I graduated. I left medical school 30 years ago, so this is the way we used to learn, that the importance to have the mother and the baby left alive and more or less functional. This was enough, And so this conception, it is changing radically, but the training of providers and institutions in Brazil has been very slow to incorporate this paradigm shift. So many initiatives from outside the medical education system are being provided for the professionals to update themselves. So we have in Brazil almost a universalization of cesarean section because it is considered to be the gold standard of care. It's the care, that many women believe. This is changing, as I will show you, but many women believe it's safer, it's more comfortable. This is the reason why women should go for that. But the new generation, there's an increased demand for spontaneous birth for the reason I'll show, that understand childbirth is a neuroendocrine, epigenetic, and microbiome formation process with lifelong effects for the offspring. So, is that many of the issues that birth is a complex neuroendocrine phenomenon, and the labor itself has a very important role in epigenetic formatting, I will discuss a bit with the students about epigenetics and microbiome of birth in the Tuesday, I think, in the presentation. And we go a bit more into details of this epigenetic thing, phenomena, and so on, and all the biological evidence on this, but also the importance of how this hormone, they set this epigenetical characteristic for the transition, for the fetal to neonatal transition. So oxytocin, it promotes not only contraction, confidence, and love feeling, but also it has these epigenetical effects. And also the endorphins, besides relieving pain and this feeling of euphoria that women have when they are when they have the endogenous hormones, which is different from having external hormones. So if you have synthetic pitocin, oxytocin, this blocks these epigenetic changes and have important epigenetics harms in terms of the baby prognosis. So, and also the other point of this new interpretation is the role of stress hormones, especially the idea that we have this stress, which is toxic stress that can happen in childbirth. You know, this toxic stress can have harmful consequences, including brain injury and so on. This is a toxic stress. You can have eustress, which is the physiological stress, and it's necessary for these epigenetic changes. You know, it's expected that both mother and babies have adequate levels of catecholamines, of stress hormones, for them to go through the labor and birth properly. You know, and these turns in and off some genes in the baby and in the mother. And you have to not only the distress and the eustress, but you can have the astress. The astress is the absence of the presence of this stress. When you don't have these hormones, you don't have the epigenetic changes that are necessary for the fetal to the neonatal transition. This is the reason why the respiratory, the metabolic transition for the baby is so difficult for babies who do not go into labor. There's very robust evidence about this. So the other thing that these hormones have very much to do with the so-called golden hour, with the first hour after childbirth. So the level of alertness that the baby has for this interaction with the mother, it's been a top research subject presently because it's very important, including for the establishment of breastfeeding, and also has an impact on morbidity and mortality, both for the mother and for the baby. WHO has a campaign about the first hour, the golden hour, and also it has an impact on the emotional formatting. It sets the reaction to stress. If you compare babies with or without this kind of stimulation, you know, the metabolic adaptation, social and cognitive development, this childbirth experience. We used to believe when I left medical school that babies did not have memories of childbirth, but it's not exactly what you call memory, but there's several kinds of cortical imprinting in childbirth that has long-term effects. So all of this has an impact on how we think about the routines and ambience. Usually these ambience have been not aimed at facilitating physiology of childbirth because women need tranquility, comfort, safety, privacy, etc. Our settings usually are focused on providers' convenience to the detriment of the needs of the mothers and baby. I'm also suggesting the reading of this material. There's another material of the childbirth connection. This one is how to organize ambience. They are physiology friendly for mothers and babies. And this is a material for consumers, pathway to a healthy birth. That's for consumers to navigate the system in the case of the United States. So I'll tell you something about what are the epidemiological evidence to the long-term consequence for these babies and for the mothers of the different modes of delivery. We can have the short-term, the long-term. And again, I will insist that a well-indicated C-section is a very important resource and has to be available for everyone that needs, you know. However, its success produces adverse effects in mothers and babies, and these effects have been poorly studied, so they are very important research subject by now. But women must have the right to informed choice of mode of delivery. This is a controversial issue, but I think that women are entitled to decide what kind of mode of delivery they prefer. It's a matter of human rights. And this is very much contextual, because in some places, women have access to a very physiological, humanized birth care. In some places, she doesn't have. And sometimes she has to choose between a very aggressive form of childbirth care or a C-section, and it's sometimes wiser to have a C-section when childbirth care is very aggressive. So, for instance, if the woman has to deliver in a very stressful situation, she's physically restrained, she has a mandatory episiotomy, they're going to cut her vagina, then you're going to do fundal pressure, she will be no companionship, and so on. Childbirth can be, for instance, if people use routine oxytocin, this adds risks and more risk in this vaginal birth. It's not as safe as it could be. So this is very important to consider the issue of the right to informed choice, but also that choice never works without the context, you know, it depends on the context. So, and we believe that everything that's good for the mother is good for the baby. This is a very important statement to be made. So what we know from the best evidence, we know that in the short term, babies born by C-section have more preterm delivery, low birth weight, difficulties with breastfeeding, bonding, etc. But what is new is the medium and to long-term effects. That's an increase in overweight and obesity, asthma, type 1 diabetes, allergy, metabolic dysfunction, and other non-communicable disease. I'll talk a bit about this. I will talk more about this in the subsequent lecture. So first of all, these epidemics are complex and multifactorial, you know? There are many issues involved in this, including excessive calorie consumption, ultra-processed food, nutritionally poor food, sedentary lifestyle, and other social and structural factors. So this is important to say, you know. Cesarean section and the change it makes in the gut microbiome is one more factor, and one that's most easily modified. This is the reason why people are investing so much in changing childbirth. So what is the populational evidence we have to say that we have these long-term effects in the epidemics of non-communicable disease? First of all, I was trying to make this presentation short because I have these Google alerts about the issue, and every week there's more research on this. But I'm going to show, as we discussed it yesterday, when you have that hierarchy of evidence, you know, the systematic reviews, they are kind of a knowledge synthesis that facilitates us to think about this issue. So I brought here a systematic review about mode of delivery and offspring body mass index, overweight, and obesity in adult life, because we tended to think that this difference in mode of delivery could be resolved, you know, in a couple of years. But these are differences that go to adolescent and to adult life. So one of the invitations I would do for you, if you have birth cohorts, everybody is reanalyzing their birth cohorts to study retrospectively, comparing mode of delivery regarding overweight, obesity, and non-communicable disease, because there is a difference on this. So in Brazil, we're doing this with our cohorts. So these are all reanalysis of cohorts that did not include this kind of thinking because we didn't know about this. So it concludes that there's a strong association between C-section and increased offspring BMI, overweight, and obesity in adulthood. So we should study more, controlling for all other potential confounders. This association is very strong. This is a study that was published a couple of months ago. This is a very interesting one, published in JAMA Pediatrics, that it shows that there is increase in obesity in children, but also it's very interesting because it compares also the siblings. When one was born by C-section, the other one was born by vaginal delivery, because you have the same genetics, you have the same eating habits within the family. So it's very good to compare. And it concludes that in the case of sibling, the additional risk of obesity is 64%. So this is very strong association and very well controlled by all these factors. Also, cesarean section has an increased risk for type 1 diabetes in young adults, in adolescents and children, in asthma, in children and in adults. And there was published this very large European cohort showing that many chronic diseases such as asthma, rheumatism, allergy, bowel disease, and leukemia also, some forms of are also more frequent in the offspring of cesarean section. So there is recently an international alert for us to study these outcomes. People who have data on this, it would be very useful to reanalyze. So why is cesarean section associated with non-communicable disease? What is the evidence on this? So this is the explanation people are doing. There was a lot of investment in the Human Genome Project. It took a lot of years to decode all the human genome. And afterwards, it didn't explain much, But it was very important because we developed the technology to use genetic sequencing for bacteria, and we learned very much about this. One of the things is that babies born by vaginal delivery, babies, when we are born, we human beings, we are relatively sterile, We have little contact with bacteria, protected by several forms of protection, the amniotic sac. There's a whole immunity of the intrauterine life. So when we are colonized, after we are born, we are colonized, we call the first inoculum. So those bacteria who reach the baby's immunity first, it occupies many of the sites, especially the most important site to be occupied, and the center part of the microbiome is the gut microbiome, but not only, the respiratory microbiome, the skin microbiome, and so on. Those born by vaginal delivery are first colonized by lactobacilli that are especially useful because the baby is good. They are necessary to digest the milk, while those and sets the foundation of a healthy immune system, So the inflammatory characteristic, metabolic characteristic of those both by vaginal delivery is different from C-section because the first inoculum is hospital bacteria. And right after that, the bacteria of the skin of the family. So there's a whole debate. If you search for this in the internet, you're going to find thousands of stats because this is a very hot topic. So there's a very interesting interrelationship between the epigenetic changes of the perinatal period and how this intersects with what is called the intergenerational transmission of the microbiome. And I think it would be very interesting because this is very much related to its environment. So the healthy microbiome here in Kerala is different from the one in São Paulo, although there is let's say, a core of bacteria that work more or less the same all over the world. So this is a very hot topic also to study. And as bacterial genetic sequencing is getting cheaper and cheaper, this is a very important thing to study. And because we can correlate this with health outcomes. I very much suggest this documentary that's called Microbirth. It's a very interesting one that tells a bit about this story for consumers. And I'll tell a bit about the Births in Brazil survey because for us to put together the information that we had up to now. So in Brazil, babies are being born more smaller and more immature. every census we had babies smaller and more immature, so we have an increase of babies born before 37 weeks. We have up to 90% of them. That's been increasing from 6 to in the 80s to in 2015 we had 20% in some places. Why this is extremely important? Because we changed the idea of term babies. Term now is 39. It's not 37 anymore because there's a difference in brain development. When the brain development inside the uterus is different from outside the uterus. We know this now. And so there are several disadvantages of the babies that are born before term. So this is a paper that we recently published showing what we call the left turn in gestational age. Let me show you the curves, The curves that are more to the left are private and C-section, So being the private sector, although women are wealthier, more educated, they tend to have babies who had shorter gestational age. They are more preterm and they more early term. Early term are the babies that are born from 37 to 39 weeks. Why this is very important? This was published a few weeks ago. They compared babies born from 37 to 39 weeks with babies born from 39 on. And it says that before less than 39 weeks, planned birth is associated with an elevated risk of poor child development at school age. The timing of planned birth is modifiable, and strategies to inform more judicial decision-making are needed to ensure optimal health care and development. So this is very important, and women should be informed about this when they think about choice of delivery, because this has a very important impact on the baby's cognitive ability later. So to finish, I will bring what in Brazil many people, especially people of the humanization of childbirth movement, think is going to be the gold standard of birth, You have here, this is not for everybody, Women who have medical complications need high technology, need intensive care, need drugs, need surgery, and so on. But most women can have a birth like Kate Middleton had, Also, these elite women tend to be the trendsetters. And she had the baby in the 42nd week, with no interventions, assisted by midwife. It's not that technology was not there, Everybody was ready to help her if necessary. But the gold standard is beginning for many women, unmedicated birth, where she could have for herself and for the baby the best outcome, not only in the short, but in the late term. So thank you very much for your attention.